Welcome back to Oncology for the Inquisitive Mind, our post-ASCO spectacular, and we are thrilled to welcome back a man who is very much a friend of the show, one of our favourite guests to have on, Dr. Adam Brufsky. He's been a guest, has wasted his time on this podcast a couple of times now, but if you haven't listened to his previous episodes, thoroughly recommend you do so. Dr. Brufsky is a alumnus of the University of Connecticut School of Medicine, a veteran of Brigham and Women's Hospital, Harvard Medical School, and the Dana-Farber Cancer Institute, a current principal investigator of the Pittsburgh Breast Cancer Consortium, and a attending physician of the University of Pittsburgh Cancer Institute, and in general, an all-around lovely guy. Adam, it is great to have you back.
Thank you so much, Michael. Welcome. Thank you, guys. It's fun to be here.
So we cannot think of really too many people, really anyone, better placed to speak about highlights in breast cancer from ASCO 2025, especially because, as you mentioned before we started recording, you are basically 3 hours post-ASCO.
That is correct. Right. I would have given this from ASCO had I had to stay an extra day. I came Thursday and I stayed till Tuesday. So, yeah, I would have, I'm literally right off the plane, 2 hours off.
Amazing. Hot off the press. So I think what we're going to do, Adam, we'll let you take the lead just to give us an overview of some highlights, promising trials, things that might be practice changing, and your take on just, the vibe in the breast cancer world.
Yeah, it was really a spectacular ASCO. And I think that, although the top line, it's interesting. The best way to describe this is some really, really cool top line data. I mean, we'll get into it a little bit more. But as, again, it's just so fresh in my mind and in everybody's mind. I think a lot of us have started to think a little bit about the data. And it's really interesting, but it does raise a few questions, actually, about how to interpret some of the more important pieces of information that we saw. I mean, there's just so many things to talk about at this ASCO. I mean, you guys can probably lead me. I don't know which way. You can start leading me and we can figure out which direction we'll go in. But there's a lot to talk about, I think. And the vibe was good. We're all very, very excited. I think there's an enormous amount of choices available to us now. And really, I think SERENA-6 in particular is a paradigm shift in how we think about cancer in general, not just breast cancer, but all cancers. I mean, literally a clinical trial where we made a change based on a molecular test, not necessarily clinical progression, and saw a benefit in terms of progression-free survival, which is spectacular. But on the other hand, what do you do with the data? How do you implement it in practice? I mean, Serena, DB09, we're going to talk about that a little bit. TDXD as the first line, that's great. But on the other hand, can we still use it second line? Do we really have to use it first line? There's a lot of questions that come out of all this stuff. And, there's just a lot more, even more than that. I mean, there's a ton of things to talk about. But I'll take the lead from you guys because there's just so much to talk about here.
Well, Michael, I might interject because these two trials you just mentioned, I've sort of kept my finger on the pulse, being a very baby breast oncologist myself. I'd like to get your take on DB09. And the reason I bring this up is that, when you look in the Twitter sphere or the X sphere, whatever you want to call it, people are like, this is practice changing. This changes the paradigm. And I always find those comments quite, maybe because we're Australian, Michael, I don't know, but I'm like, let's take a step back because it's not as simple as this is the new standard of care, especially when you've got people who have been on Herceptin for 12 years, no side effects. They've been on those original trials. And you're like, well, TDXD isn't without its side effects. So what's your take on DB09? And maybe from a people listening, just what was the comparator arm, how made this change our practice?
Sure. Well, the standard of care, as we all know, is THP. So it's a taxane, be it docetaxel, be it paclitaxel, with trastuzumab and pertuzumab. That's a standard of care. 6 to 8 cycles. Even though people like me were giving more, I was giving it until people got toxicity. I was a little more aggressive than my colleagues. And then at that point, if you had ER negative disease, you had HP maintenance. If you had ER positive disease, we went from HP maintenance with an AI to now in Patina, which was presented 6 months ago, HP maintenance, AI, and a CDK4/6 inhibitor, in this case, palbociclib. And with that regimen, we had a PFS of 44 months. So remember that number in ER-positive disease. So the trial was 3 arms. It was TDXD front, again, people with metastatic breast cancer, obviously. That was HER2 positive by the typical assays, be it IHC or FISH. And they were randomized 1 to 3 arms, but they only reported on 2, which is kind of interesting in and of itself. It was TDXD every 3 weeks with pertuzumab, TDXD by itself, or THP, and the T could be paclitaxel or docetaxel. And I think there were 6 to 8 cycles or something. I forgot the number. It wasn't until progression, the THP. I think you had to stop. And the typical kind of Cleopatra regimen is you stop after 6 to 8 cycles and just go on HP maintenance. And that was the design of the trial. They did not report on the DXD alone arm, by the way, which is really interesting, and no one really knows why. They said, I think, again, this literally was presented, I guess, well, in Australia, it's kind of 14 hours later, but for us, it was literally yesterday morning. So we're all still kind of trying to figure it out. But Sarah Tolaney, when she presented it, said that there weren't enough events yet, apparently, in the monotherapy arm with TDXD. So we don't know really what that showed. But nonetheless, in the TDXD followed with P arm, you had a progression-free survival of 44 months, or 40 months, I'm sorry, versus I think about 27 with the THP, the standard of care, which was substantial. It was a hazard ratio, I think, of 0.57 or something like that, which is great. And we all say, okay, that's cool, fabulous. And we're all really excited about top-line data. And then you start to think about it for a minute. And you ask, the first question you got to ask is, well, wait a minute. If you're if you have ER positive, HER2 positive disease, you can get 44 months out of the standard of care, right? So with all drugs that basically are generic or biosimilar with the exception of palbociclib, and palbociclib is even generic in parts of the world now. So, in thinking about it, you got to ask yourself a question. You're still getting the same PFS in the first line. So then you go to PFS2, right? Which Dr. Sarah presented that, Dr. Tolaney presented that. And the PFS2 in the control arm, which is again, PFS2 being, as first line progression, then after second line progression, was 36 months in the control arm, and it was not reached in the TDXD arm, which sounds great, right? Because the thing is, what you're thinking about, one thing people were thinking about when they were thinking about this study was that you can go on the Cleopatra-like regimen, right? And we know the control arm of Patina, which was basically was 29 months. And we know that DB03, which is TDXD in the second line, has a PFS of 28 months. So if you add them together, that's 56 months, right, for a PFS2. That's what you expect now up front. And we don't know if that's going to be the case. And when you look very carefully at the study, what the patients got as second-line therapy, only 10% of the patients in the control arm, that is the TDHP arm, got TDXD. So it's not a true fair comparison of early versus late TDXD. And, while the top line looks great, 36, 3.5 years PFS in a frontline trial of metastatic disease is spectacular. And I think it will become the standard of care in a lot of the world. I don't have a problem with that. But I think we need to think about all of these other subtleties of the study, that in fact, one could argue you still could give the regimen the other way. You can give the TDXD. It depends on where in the world it's available. I don't know, Australia, what line it's available for. But the thing is that if it's available at all, I think it is available. And I think that, you could give the standard of care and then give the DXD afterwards. And I think that's really the big question. Are you preventing deaths, for example? Like people, the whole thing in oncology is give your best drugs first, right? And maybe there are rapid progressors who would potentially die, who you're salvaging by giving them DXD instead of THP. That's a possibility that we have to think about. But on the other hand, we know we could potentially get a PFS2 of up to 50 months, if not more, by doing the standard of care. So right now, as it exists, with DXD being given as second line. And so it's going to be a really interesting, that's one of many issues that have come up on this trial. The other one is, DXD was given until progression, right? It was given for 40 months, and that's median. So a lot of people were getting it for 3, 4, 5 years. So the thing is, only I think 12 or 13% of patients got concomitant who had triple positive disease got concomitant aromatase inhibitor. And, so what do you do about the patients that are triple positive? If you wait 4 years or 3.5 years to give them endocrine therapy, that really raises an important question. So I think what a lot of people may do this is my guess. It's based on no data, no anecdotes, nothing. But I think a lot of people were talking about maybe using DXD as kind of induction for some amount of time, be it 6 months, be it a year, be it 18 months, whatever. And if you hit some sort of either CR or stable disease with the DXD, switching to some sort of maintenance, either HP or HPAI and palbociclib. And I think that could be what happens in this trial. I mean, clearly, the drug is very active. It's changed the nature of the business. There's no doubt about it. I think the question is going to remain where we put it. I mean, had the PFS been 50 months or something like that, I think it'd be no question. And that's the problem. We're so spoiled by DXD. We're like saying, wow, this is great. It gave us 28 months in the second line. We want 50 months in the first line. And when we didn't get it, we're like, we're so spoiled in breast oncology now by this drug. But nonetheless, it is a pretty impressive PFS. The bottom line is women and the occasional man with first line HER2 positive metastatic breast cancer really can expect at least 3 to 4 years, I think, in the first line, regardless of what you do. And I think that's a big deal. I mean, that really is a big deal. One of the other things I'm really going to be interested in is a few things I'm going to be interested in this trial. I'm sorry, you've got me going now, so I'm on a roll.
No, this is good.
One of the things I'm going to be really interested in on this study, there's a couple that we're going to see probably in the not too distant future. The first one doesn't prevent brain mets. We know it has CNS activity, and so we didn't report on the brain mets yet. Another thing that will be very informative for everybody is that obviously the ILD was 12%. You had to come off. But there were other people who came off for a variety of other reasons, discontinued the drug. What I want to know, and they were put on HP maintenance, right? HP and AI and whatever maintenance. I want to know what that PFS of those patients is, because that could really inform a strategy of induction for us. If that PFS still is 40 months, because it was an intent to treat trial, if that PFS was still 40 months, then that will help us figure out whether we really could get away with an induction strategy, give us some information. That was not presented yet. So those are the sort of things I really want to know. I think that probably in my practice, I will strongly consider this as the first line standard of care if it gets the label in the US, and I think we all expect it will in the next 6 months or so. I think a lot of us will use DXD first line. But the issue is, what do you do second line? Because again, I think that the PFS2 that was shown, it is gratifying though. That's the third thing actually that I want to look at in DB09 is what the PFS in the experimental arm is going to be, because it was not reached yet, the PFS2. And so if the PFS2 really turns out to be about 40, 45, 50, 60 months, well, 50 months, then I'll be happy. Then it's okay to give it in that direction. And I think to give it first as opposed to second. I'll be okay if the PFS is only 40 months or something, which I doubt it, because it didn't look like that when you look at the curves yesterday. I think that those are the sort of things I'm going to want to know about this trial. And those will come out as the FDA is kind of wending its way through it and giving the approval for the label expansion in the US. And we'll probably start using it here first, because we'll probably get the label for anybody else. But I think that it's an interesting trial. But again, as you said, Joshua, is it practice changing? It's further evidence that the drug has changed practice, I think is the best way to say it. I don't know if it's necessarily a new paradigm, but it definitely is an important study that really informs us a lot and just says that the prognosis of women with ER positive or with HER2 positive metastatic disease has just changed dramatically. I think it's probably the best way to summarize that study. But I'll answer other questions you have. Again, you got me going here. I went for 10 minutes on it.
It's brilliant, and this is why we love having you on. I mean, you're just such a font of knowledge. I did have a couple of very small questions, really, just picking up on details from what you were talking about. You mentioned that there were not enough events in the TDXD alone arm, which is interesting given that it's sort of the arm that has quote unquote the least treatment, because you've got TDXD plus pertuzumab and obviously standard of care. Do you think it was just because, I don't know, was the population that got TDXD alone smaller, or is there anything that we can read into that?
No, it was a 1-to-1-to-1 randomization. No, I mean, it's really weird. It could be statistical, just statistical play a chance. I don't know. And I think that the hope is at ESMO or San Antonio, we'll see further data and be able to understand that. Because there was a trial that you guys may not remember because you're babies compared to me, so there's a trial called Marianne that you may be familiar with that was done probably about 12, 14 years ago. And it was a similar trial, except it used TDXD. It used TDM1. It used kind of the ADC of the time. And so it was TDM1 pertuzumab, or TH, docetaxel, trastuzumab, because we didn't have pertuzumab back then. And there was no difference in the three arms. I mean, there were small differences, but they were not statistically significant. That killed TDM1 as a first-line therapy. And so, a lot of us who see this data now are kind of thinking back to that. It's a very similar design to Marianne. And I think a lot of us are thinking about this. I mean, clearly there's a clear difference between DXD up front versus the standard of care. I mean, 40 versus 27 months, the hazard ratio 0.57. It's a clear difference. It's not like Marianne at all. But it's just interesting, because there was no difference in Marianne between TDM1 and pertuzumab. That was clear in that trial. I think it was like a 15 month PFS in both arms. So it's going to be really interesting to see what that DXD alone arm is. Maybe you don't need the pertuzumab. That could be possible. We'll have to see, though. We just don't know.
And with the PFS2 for the TDXD and pertuzumab arm, was there data on what patients were getting? I mean, I'm sort of assuming it's sort of TDM1.
Yeah, they actually had a slide of that. Only 10% or 10 or 12% got DXD in the control arm. Did they? Yeah, give me, hold on one second. Actually, while we're here, I'm going to pull that right up because literally.
I guess.
Go ahead.
Sort of thinking in very simple terms, because I'm a simple kind of guy, nowhere near the breast oncologist that you two are. But the thought for me would be that giving sort of THP after TDXD is, I don't know, to me that seems like it's less likely to be effective. So presumably you'd go to TDM1 or even cytotoxic chemotherapy. Is that what ended up happening?
Yeah, so I'm looking here. I'm literally looking at the slide, and 1.8% of the patients, 7 of 383, got a TDM1. So about 17% got chemotherapy second line as PFS2 in the post-progression treatment, and that was divided between docetaxel, paclitaxel, and CAPE. So it sounded like a lot of people did get THP second line. Some probably got CAPE, trastuzumab, second line, and very few got TDM1. A few even got DXD afterwards. I don't even know how that could be. I can get DXD afterwards if you've progressed on DXD and pertuzumab. But I'm just looking at this right now, and that was again, this is very immature data. But again, the thing that really surprised me was that only 10% of the patients in the THP arm got TDXD. And, so that's not a really fair comparison because that's really your best regimen in the second line. Now, again, this is a worldwide trial, so probably this is a way for people to get TDXD. I don't know whether AstraZeneca allowed or supplied TDXD at progression in the control arm. I just don't remember or know. So it's just really interesting, to see in both of the arms of the trial what's happening, both from the THP arm, the lack of DXD in that arm, but more importantly, they didn't really name the regimens. They just named the chemos and stuff like that. So it's going to be really interesting to see what happens. That PFS2 is going to be very, very important because we just have no idea what to do. We have no clinical trials at all in a post-ADC setting in breast cancer.
Which is sort of the next frontier, I guess, is we have, as you say, victims of our own success in this sort of space. But then obviously what comes next?
Yeah, there's a lot of talk about, in fact, a lot of trial designs that are both being done and being proposed by various companies with novel molecules, and basically almost all of them are going to require TDXD or in the case, maybe trastuzumab govitecan, up front. You're going to have an ADC first before you're randomized to the next arm of the study. And this will be really good. This trial will be good for two reasons. One, they'll test whether novel therapy works, but more importantly, they'll give us a control arm for actually knowing how people really do, the natural history of people after an ADC, which I think is really important.
Brilliant. Adam, the other trial you mentioned at the top was that sort of got your excitement going, got your juices going, was Serena-6, which is a very interesting study design because it's so heavily based on dynamic molecular changes, which is not something that we see too much really anywhere. But could you tell us about this and what about it got you so excited?
Absolutely. I mean, the reason it's really a paradigm shift. I mean, I think that so let me go back in history again. So we used to use circulating tumor cells 15 years ago were like the circulating tumor DNA of the time. And we had a trial, and we knew that if your circulating tumor cells were over 5 and you had metastatic breast cancer, your prognosis was bad, that within a couple of months you'd have radiographic regression, very similar to the ctDNA of our age now. And so we did a trial where we had people who had under 5 CTCs per 7.5 mil tube, but basically it was a test. And if they converted at 1 month to 5 CTCs or greater, their chemotherapy was changed. And then they did radiographic progression at 3 months. There was no difference whatsoever in each arm. Early treatment did nothing. And so the argument at the time in breast cancer world was, 1, we just didn't have good enough drugs and good enough tests, or number 2, early therapy just didn't make a difference. And I think those are two very different hypotheses that were going on. This is the first time in breast cancer where we have treated somebody based on a molecular change in the plasma and not on radiographic or clinical progression, and got a PFS advantage. That's why it was in the plenary session, I think, more than anything, because this is not just for breast cancer, this will be for every cancer. I think we now have evidence, academic evidence. I mean, we'll talk about the clinical applicability in a minute, but we now have academic evidence that if you treat somebody at the emergence of an ESR1 mutation, I think the PFS was like 28 months or something like that versus like 10 or 9 or something in the control arm. I think it was 9 actually. So the idea behind the trial again was you screened 3,000 women, and then immediately, and they had to have stable disease for at least 6 months on a CDK4/6 inhibitor and an endocrine therapy, and then half of them at the first test had an ESR1 mutation, right? And so the other, I think, probably it ended up about 11% had a mutation initially, and then over the period of follow-up, which is about, I think, another year and a half, another 30%. So you had about 42% developing an ESR1 mutation. Everybody misinterpreted the study and said only 11% because they only randomized 300 people out of the 3,000 they screened. It turns out they got 500 of them, 550, but for whatever reason, only 300 patients were put on study. There was a variety of reasons why they didn't go on trial. But the bottom line is that doing that, you still had a substantial difference. The 2-month progression-free survival was like 28% versus 5% in the people who remained on therapy. Didn't switch. Remember, so the idea was you had an ASCO mutation, you were switched to an oral SERD, camizestrant, with palbociclib, or you continued an anastrozole or whatever endocrine therapy you were on, AI plus palbociclib. And the people who got AI and palbociclib still didn't progress for 9 months. They still were okay on average. But the ones in the camizestrant arm, the median progression was, I think, 23 or 4 months. So it's really changed, again, the paradigm. We got a higher progression-free survival by intervening early. Now, the question, again, comes to PFS2, right? So in other words, are you simply just treating them with the oral SERD earlier? And therefore, at the end of, maybe they were on palbociclib, and AI and got fulvestrant and whatever second line, and that total PFS2 is the same. Well, it turns out it looks like the PFS2 it wasn't as dramatic as in DB09, but there appeared to be a PFS2 benefit. But it wasn't. It was barely statistically significant if I remember SERENA-6 properly. And so again, we need to see some more follow-up to see, because again, the argument is, are you just simply detecting disease earlier and the overall survival and the overall treatment course is going to be the same? Is going to be really the question. Now, again, I do believe there was a hint of a survival advantage that was seen, and maybe you are rescuing some rapid progressors by hitting them with the oral SERD first by detecting with ESR1 mutation. I think you are. So I do think lives are being saved by doing this. It's just a question of the degree of benefit, the amount of benefit you're getting by the early intervention. You're clearly getting something. It's just a question of how much. And again, the top line looks fabulous. Plenary session, New England Journal paper. You've got when I first saw the curves, because I'm an investigator, I'm on the study. When I first saw the curves, I'm like, wow, this is tremendous. But then when you start thinking about it a little bit and going beyond the top line data a little bit, questions start to come up. And Angie D. Michel, who was I believe she was the discussant, raised a lot of these questions in her discussion. And I think that it's interesting. But will it change the paradigm? It's going to be really question. I don't know, because a Guardant 360 is a very expensive test. And that was the companion diagnostic. I don't know what it is in Australia, but in the US, it's $3,000 every 3 months. And I think what's going to happen in the US, where this likely will get the approval first, is that people will try to pick and choose who should get screened. They're going to, in their mind, they're going to have people who they think are going to be ESR1 converters. And they're probably going to think about screening those patients first. But there's nothing right now in the study that clinically predicts who would have an ESR1 mutation or not. So I don't know how we're going to do that, but I suspect people are going to, in their mind, try to figure out where the pretest probability is highest, for example, even though we just have no way of doing it. So that's kind of again, you get going on this, I'm going to keep going forever.
Yeah, it's a great study. And I think you hit the nail on the head that it's not so much the study itself, but the way, to an extent, the design has been built and incorporating, ctDNA to try and pick and choose who you change treatment for. And I guess one of the questions I had is that, do you actually consider PFS2 a good second, that's one of their secondary endpoints, right? But is it technically a secondary endpoint, or is it technically PFS2, or is it PFS3? Because you've already switched, so you've switched it to another drug, right? But then the counter argument is, if you're actually extending the life of that drug, and take aside, let's say money is not an issue in this in this question or this scenario, you just continue switching, right? If you stop PFS, and wouldn't you just jump and jump and jump if you've got another mutation that you can just adjust? That's the golden scenario.
That's the ultimate scenario. And in fact, I think, honestly, there'll be trials like this with PI3 kinase inhibitors. Because I don't know if we're going to talk about ANOVA 120, but the survival advantage, but an overall survival advantage. So, the bottom line is, yes, I think there could be a time where, we treat people not based on scans anymore, but based on levels of ctDNA, because that's a whole other theme of the meeting, and people are looking at that very closely. But we treat people at levels of detectable ctDNA, levels of ctDNA, and when the allele fraction gets above a certain amount, the mutation you find. And we may go away from scanning and just simply treat people based on that and see what happens. I think that's the far future. I don't think it's the next 5 years, but I think that's potentially where we're going to go, Joshua. Just like you said, I think, using ctDNA, and as the mutation profile of the tumor changes, altering your therapy before you maybe see radiographic progression. Yeah, I would agree with that.
Yeah, it's really, I don't know, I think this really excited me. Just take aside all that other stuff. And going back to the first trial, DB09, we talk about financial toxicity. TDXD is an exceptionally expensive drug compared to Herceptin, right? And while yes, you've got an incredible PFS, it is also that scenario. They bring it up every time in breast cancer because we do have so many treatment options. It's is the standard of care correct? Is if there's no sort of switching in second line therapy, or you can sort of do a crossover, like can you do true comparisons to actually figure out sequencing of drugs? And these are those high level questions that no one can answer. But I do realize we have a time limit. I do have to get to work eventually this morning, but I think we'll cover 2 more trials. I think
Sure.
the two, so Inavo 120 will be really interesting if you're happy to talk about that. And then maybe Michael finish off with just what you think is the most inspiring or, potentially other trial, your personal favorite. If you're happy to start with Inavo, and then I'll let Michael finish us off.
Yeah. So again, Inavo is it's a Roche-developed PI3 kinase inhibitor, and it has all the typical PI3 kinase toxicities. I mean, a little bit less hyperglycemia, but still has it. With these drugs, you get hyperglycemia, rash, and stomatitis. And I think that it's a little bit less, but it probably pretty much behaves like, say, capivasertib, or maybe a little bit better than alpelisib. But basically, it's kind of the same. And so the idea behind this, you took patients at very, very high risk. I mean, these are really high-risk patients. And we were discussing this at a meeting, I think 2 days ago, after that happened. We're talking about how common are these patients really in practice. But these are people who progressed on a CDK4/6, on an aromatase inhibitor, or I think within 12 months of completing the aromatase inhibitors. They were higher risk patients, and they had to have a PI3 kinase mutation. So they had next gen sequencing and when they presented as metastatic breast cancer, and if they had a PI3 kinase mutation, they were randomized to a triplet of fulvestrant, palbociclib, and inavolisib, or fulvestrant and palbociclib. And initially, the data was presented at San Antonio. The PFS data was presented, and it showed a clear benefit. In terms of PFS, it was doubling. I think it was like 13 versus 7 months or something like that, which was okay. And people were going, okay, yeah, it's PFS. And, these drugs are toxic, and, we don't have overall survival yet. And so we're not, and the use really, I think, was only available in the United States, as far as I know, off label or off trial. And people really weren't using it as much in practice as I thought they would. And we really weren't screening women up front with NGS as much as I thought we were going to. But now we have a survival benefit. There's a clear survival benefit. I think it's like 37 versus 20 months or something like that. And it's dramatic. It's like the hazard ratio is like 0.44 or 0.5 or something like that. And so now you're kind of almost committed in those patients, because there is a survival benefit, to seriously thinking about giving them the triplet. And I think it's going to be really interesting to see, A, who are those patients really? Are they the woman who comes in with a solitary bone met, during her year 8, she's on extended endocrine therapy and she's year 8 and has a solitary bone met? Or is it that woman who progresses after a year and a half of therapy and has a liver full of disease? I mean, you see what I'm saying here? It's not I think we're really going to think, again, just like with SERENA-6, who are those patients really in the trial? Who do they really represent? Because a lot of people were thinking, gosh, this doesn't sound like a lot of patients I've ever seen. Yeah, we have patients that progress really fast, but they tend to be people who kind of our ER is low, they're almost basal in their nature, they're not quite ER positive. And so this is a really interesting study in many ways, but clearly there's a survival benefit. If you identify the proper patients, there is a survival benefit to this strategy. But it also raises a bunch of different questions, like what do you give afterwards? You've used all your great drugs. I mean, what do you give? Chemotherapy, an ADC, probably. That's going to be the question. But it's a really, I think that, again, we're in the U.S. We're probably going to have to confront this dilemma first, because I suspect it's going to get the label. It's already approved in the U.S. So the usage probably will go up. It probably will get guidelines approval. I think it'll be pushed up the guidelines now. The evidence base in, say, NCCN, I don't know if it's a 2, but it may go to a 1. So people will probably use it more, and we'll have to see what happens. But that's my take on that trial, is that it will probably, in the patients that are eligible for it, probably drive use.
I mean, you brought up the ambiguity of who is sort of these high risk, because I'm looking at the study schema for Inavo 120 now, and they basically, from what I can see, defined high risk as progression during or within 12 months of adjuvant endocrine therapy completion. and then they obviously screen them. But that's obviously not the only thing that, as you said, labels someone as high risk. I guess in your practice, Adam, how would you, or what would trigger you when you're looking at a patient to go looking for the PIK3 kinase mutation, or would you just sort of screen everyone up front because this is, would you sort of think of this PIK3 kinase now in the same way you might think of, say, BRCA, because there's something you can actually do about it?
Yeah. Well, there's, as you know, about 30 to 40% of women with ER-positive breast cancer have it, even at diagnosis. So the short answer is I will start doing next gen earlier. I will now do it on the biopsy. We always have to get a biopsy of someone to prove they have metastatic disease. I'll just simply ask, either I'll do a liquid or I'll just just add the next gen to the biopsy when it happens. I'm going to do that now. The question will be is, if I'm going to do it on everybody, the issue is going to be who really is going to get the inavolisib. And I think that's a bigger question. And I still think in my mind, it's really going to depend on a lot of other features. If they have a very quick progression, like it's a year or two after they finish their adjuvant chemo, maybe they'll get that. But that raises a completely different issue. A lot of these women will be on adjuvant CDK4/6s, and I think Erica Mayer was talking about this. They presented a poster of the characteristics, only 20 patients, it was a really small number, of what people who progress while they're on CDK4/6 inhibitors look like. And they look really bad. They have P53 mutations, the ER is really low, they've kind of almost converted to a basal-like tumor. And so, I don't know what anything's going to work for those patients. But there's somewhere in between, I think, that we're looking at here. It's not going to be the person who progresses on year 8, for extended adjuvant therapy with minimal disease. It's probably not going to be the person who progresses on a CDK4/6 inhibitor, although we're going to treat them like second line. A lot of them will likely get ADCs up front, and then maybe some will get this regimen. It's going to be somewhere in between, and it's really going to take an art of medicine to figure it out. And I think that, to me, it'll be the ones that progress, again, with a 2 to 3 year range, that maybe didn't get a CDK4/6 inhibitor and surprised us, or did get a CDK4/6 inhibitor, and now it's more than a year after they finished their CDK4/6 inhibitor. So maybe they're year 4. So they did their 2 years of abemaciclib, and now they're year 4, and they present with metastatic disease and have a PI3 kinase mutation. I think maybe those are the ones that they'll give the triplet to. If you have to think of one patient in my mind, that's the one I'm thinking about, I think, more than anything.
And you preempted my next question, which was going to be how the adjuvant CDK4/6 complicates things. So there you go. It
complicates everything. It's total. We have no idea what it means. Although, it's interesting. There was a really interesting preclinical study that floated around probably about, 2 or 3 years ago, where someone treated cells in culture with CDK4 until they became resistant with CDK4/6 inhibitor, and then let them sit and grow for another 9 months. And if you let them sit, they reestablish sensitivity to CDK4. Now, is that translatable into human beings? We don't know. But it's just interesting to know that it's possible, at least in theory, scientifically, that you regain CDK4/6 for whatever mechanism. And I don't think anybody understands the mechanism. But apparently you may regain CDK4/6 sensitivity if you're off them long enough. We hope.
It's an interesting point, Mark. I'm never going to get to work at this point, but that's fine. Just the whole idea of it's fine. It's good. Yeah. It's this is the problem when you come on, Adam. I'm just like, this is my list, and you're probably exhausted after 5 days and multiple meetings. But we do appreciate coming on. Is that back in the day, and I'm talking about when Michael and I started training, which is quite recent. But you look at these people who've had metastatic breast cancer for years, and this is before CDKs really became big, and you can see that they're switching through backbone of their endocrine therapy over many years, and some of them do get ongoing responses. They're on an AI and they switch to tamoxifen in the 4th line after several, and you see this stuff. And I remember seeing just one patient, the list was this long of all their treatments, and they've been alive for years. And you have to ask the question, that endocrine resistance, how that's actually where the physiology is changing and the pathology is changing. The same with CDK and even HER2, the downregulation of HER2 receptors and then all that sort of stuff. So just interesting.
Because patients, the thing is, we're so successful. What we've done in breast cancer. I mean, when I started 30 years ago, we had what? Tamoxifen, maybe adriamycin, maybe aminoglutathione. I remember that's it. We didn't even have aromatase inhibitors. And, I don't know if we're going to get to this trial, but I was talking about TROPiCS-02, which is 4th and 5th line, trastuzumab, govitecan. We're randomizing people with a median of 4 years on therapy for metastatic breast cancer to 5th line therapy. That's where this business has come. And I think, the science now has to catch up with it, Josh, as you just said. We have to figure out what's going on in these women now. What's going on in these patients, who've been on all of these therapies for multiple times. There's probably untold amount of heterogeneity that is really difficult for us to measure. And how do we treat that properly is just really, it's going to be for you guys to figure out. I'll be retired by then. It's for your generation to figure it out. So,
happily retired, hopefully.
Yeah, but yes, I will be, I hope. Yeah.
I think I want to ask you one more question, Adam, before we let Josh get to his clinic, and for you to have some well-earned rest. We've talked a lot about studies that are likely to have some impact on daily practice. They're pretty much ready for prime time. Was there anything at ASCO in this space that you thought, "Ooh, that's really interesting"? And I wonder how that will impact things in the long term. Maybe not ready for prime time just yet, but with a little bit of time in the oven, this could be something that is very, very exciting.
There's one that came out was yesterday afternoon. It had to do with a trial called Compass PCR in the United States. And so what they did is they gave 4 cycles of THP. It could be paclitaxel or docetaxel THP, but it's really 12 weeks of therapy basically. And they looked at the PCR rates. This neoadjuvant therapy. And the PCR rate was 63%. And that is a relatively non-toxic regimen, giving a PCR rate of 63%. Now, they don't have the event-free survival yet. But that, to me, that is going to inform a lot of things going forward. In particular, there's a trial called DB11 that's going to present at ESMO this year. And DB11 is 4 doses of DXd in the neoadjuvant setting, followed by THP times 4. Okay, and there was compared to AC THP, and it was better. That was the only, as a single agent, actually it wasn't. The DSMB closed that arm, believe it or not. So it really was a trial of TDXd, THP times 4 versus AC THP times 4. And if THP times 4 gives you 63%, you would, that number had better be pretty good in DB11. So it had better be like 80% or something, or 75% for people to really switch wholesale. So that study, I think, really is going to inform, if that's kind of the question you're asking. I'm not quite sure the question you're asking, but that's something, a phase 3, that's likely to inform a lot of things going forward. There's a lot of really cool stuff. I mean, we didn't even get into the Acento 4, which is definitely going to change the standard of care, and ADC first in triple-negative breast cancer. There's a lot of stuff there that really has laid the ground. I mean, this is going to be a really exciting year in breast cancer. I think that, we're hopefully, like any good trial, it's going to raise more questions than it answers. But the answers we're getting so far are really cool and really very useful for docs, for patients, for everybody.
Brilliant. I think, Adam, as always, we could talk about this all day, quite literally, but but I think that we will wrap it up there. Thank you so much for coming on.
Thank you.
We appreciate you taking time right off the plane, as we said. And if I could get in early, we'd love to have you back for ESMO.
Love to. Absolutely. Not a problem. We'll do the same thing. I have to go to ESMO this year, so we'll do it like
brilliant.
As I'm flying home. I'll be more jet lagged though, because it's a further flight. So
yeah, true.
Well, you can give us some tourism tips for Germany as well.
Absolutely.
Thank you so much for listening, and I hope you join us next time as we continue our sojourn through ASCO 2025.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.